Welcome to live Q&A with the experts of Rome Foundation. My name is Tanya Murphy, Rome Foundation's Executive Director. I'm your host, along with Dr. Doug Drossman. Dr. Drossman is the CEO and President Emeritus of the Rome Foundation, President of Drossman Center of Education and the Practice of Biopsychosocial Care. Dr. Drossman is also Professor Emeritus of Medicine and Psychiatry at the University of North Carolina at Chapel Hill. He is the founder of the Rome Foundation and is an internationally recognized scientist, clinician, and educator in DGBI and communication skills training. Today, Dr. Drossman is joined by our Rome Foundation board member, Jan Tack. Professor Tack is currently the head of clinic in the Department of Gastroenterology, Hepatology. He is professor in internal medicine and professor at the University of Louisville, and also a principal researcher at Target, which is a center for GI disorders, and at the University of Louisville. Professor Tack's research lies in the field of neurogastroenterology and motility. And I now turn things over to the esteemed Dr. Drossman.
Thank you, Tanya, and welcome, Jan. And for the audience out there, Jan is more than a board member. He's the president of the Rome Foundation. And it's been a pleasure working with him on this, with the Rome Foundation. His expertise is remarkable and extremely broad, covering many, many areas. And I don't want to take up too much time talking about his credentials, but his research, particularly the work he's just recently done with studies looking at dietary factors, anticholinergics, looking at APS, and his work looking at gastroparesis and its relationship to dyspepsia is setting the stage for our understanding of these postprandial symptoms that patients report. Maybe we'll talk a little bit about that, but what I really want to do now is to talk about the concept of rumination, because rumination is a very hot topic right now, in part because people don't recognize that they have it and doctors don't recognize. They talk about vomiting and regurgitation. So Jan, first of all, welcome. And
thank you.
Let's get on with the first question. What is rumination?
Well, rumination is actually, we're talking about rumination syndrome because rumination itself is something that all grass-eating animals do. They bring up undigested grass from the stomach, from the forestomach, bring it in, chew it again, bring it down. And there it's a physiological phenomenon. Now, rumination occurs in humans, and it is the involuntarily upbringing of gastric content into the mouth so that it reaches the mouth and can be spat out or swallowed again. And there are people who have this on a daily basis, where it's frequent, where it's experienced as bothersome, and then we call this rumination syndrome. And characteristically, it is effortless bringing up of gastric contents, food, not preceded by nausea, and definitely not preceded by retching. That makes it different from vomiting.
And the important part is that this is not nausea vomiting syndrome where you have nausea associated. This is an effortless conditioned response, isn't it? And it's remarkable. It goes back decades or hundreds of years even, but it's not been well recognized. And I know that when I see patients, they talk about I'm vomiting, and we can't take it for granted. I mean, do you have any techniques for the gastroenterologist of what he
Definitely. There's a couple of easy gains. First, want to add something to the history. You know, if you look at older web pages on rumination, it associates this syndrome mainly with children or mentally retarded people. This is a very old-fashioned view. We now have data from the Rome Global Epidemiology Study showing that this occurs in 3.1% of the adult population, a little bit more females than males, let's say 55 versus 45%. And at their mid 40s is the highest incidence age. So the idea that this is mentally retarded children, forget it. Anybody can get it. Mentally, intellectually, perfectly functioning people, I have them amongst my patients, they have it. Now, they may present in two ways. They may say, doctor, I have to vomit all the time. And vomiting is a syndrome which can happen on an empty stomach, but very often happens on a full stomach, way after the meal, and preceded with nausea. The people feel it's going to happen. They say, I'm starting to feel sick. I'm going to go to a restroom. I think I'm going to throw up. That is vomiting. If people say I vomit all the time, there's two questions that I want to know. When does it start? I actually ask, does it start during the meal or immediately after? And in rumination syndrome, it is during or immediately after. They say, I'm eating, and suddenly it's in my mouth. And then the second question I ask, and that's a bit a strange one, but very efficacious in clinical practice, I ask, if you cannot reach a bathroom to spit it out, can you swallow it again? And somebody who vomits will look at you saying, are you out of your mind? Whereas the rumination patient will say, yes, if I don't reach the bathroom, I swallow it again. This has to do with the fact that this comes with a low force up into the mouth. It's not a very heavy pulsatile expulsion. It enters the mouth, not very highly pressurized, and they can swallow it again if they choose. So if they present with vomiting, I want to know during or after the meal, and can you swallow it again? Some present like reflux disease, liquid is coming up from my stomach, and then we think of reflux disease. That is a little bit more difficult because usually reflux disease patients are put on a PPI, and then it loses the acidity of gastric content coming up, which is typical for reflux disease. And then we call it regurgitation. And also this is effortless. It comes up, it can come up into the mouth, not with a big force. So that is a more difficult one to distinguish because reflux also occurs after meals. But usually these people have a history of acidity coming up before they took a PPI. They have again acid coming up, maybe heartburn when they stop the PPI. And rumination stops a while after the meal. It tastes like the food they ate. And once it becomes acidic or a bit vomiting-like taste, the phenomenon stops. Whereas reflux comes up and continues all the time. Reflux is also position dependent. They get reflexes, they bend over to pick something up from the floor. If they carry a suitcase or whatever, just pushing up gastric content, that is less characteristically the case with rumination. So this is how these people present.
These are excellent clinical points for the clinician to separate out reflux, nausea, vomiting, and rumination. One thing I would add is that sometimes I'll see patients, most of them choose to spit it out, and it could be a variant of an eating disorder. So that's another thing to think about in these patients to maintain weight, balance and weight.
Yeah, indeed, there are some series showing that bulimia patients, for instance, also may have some coexisting and higher than expected rumination. Perfectly true.
Well, let's get to that. Who develops this disorder, and what are the criteria for diagnosis?
Well, who develops this is very controversial. I told you already in the past there was a bias linking this to mental retardation. This is a thing of the past, but still, what is really happening in rumination syndrome is that these people unconsciously but actively squeeze their abdominal wall musculature, increasing the pressure in the stomach and bringing up food all the way through the esophagus into the mouth. That is the mechanism. So when I give this talk at noon to students, to trainees, to residents, I explain this. Usually they had a sandwich, and then I asked them, now, You just had a sandwich, you ate, strain your abdominal muscle and bring up the sandwich that you ate. Nobody can do it. So there is more happening. This is happening against a background of abnormality of the motility and the anatomical structure of the gastroesophageal junction. This only starts after the meal. And so if we do manometry and administer a meal in these patients, the lower esophageal sphincter pressure after a meal is almost absent. Their muscle is wiped out, so they have like a very low to non-existing resistance between the stomach and the esophagus. That allows them, with any increase in intragastric pressure, to bring up the food upwards into the esophagus. And somebody who has an intact resistance of the sphincter at the junction cannot do that. The second thing that some of these people have is they have a slightly wider opening in the diaphragm through which the esophagus descends into the abdominal cavity. And so there's some fluctuation. They can move up the stomach a little bit, and that probably helps the upward movement into the esophagus still. So they have a basis, a motility abnormality. Then they get this habit of pressuring the abdominal wall musculature. They can do it, if you measure an hour after the meal, every 5 minutes, very frequently. So this is a habit they picked up. And why should they do that? Probably because originally they had some discomfort in that region. If you have some epigastric discomfort, common thinking and common knowledge is sometimes if you can belch a little bit, it improves. And my personal idea is that some of these people pick up a habit of trying to belch, which evolves into having this pressurizing of the abdominal wall musculature as a habit after a meal when they are uncomfortable. And why are they uncomfortable? Maybe because the sphincter is open, so some gastric content comes up, and there is a group of patients in whom there are events called secondary rumination. There's a little bit of gastric content coming into the esophagus, and then they squeeze the abdominal wall musculature, pushing it up. I think the other group have poor motility of the stomach, including the junction, and they are dyspeptics, so they have epigastric discomfort as part of dyspepsia, and for some of them, a way out, ineffective, has been the idea, if I try to belch, it will get better. And they pick up this habit of which they are not aware, which brings up gastric content all the time. I think this is what's happening. And we can come back to that later. But in some people, if you effectively get rid of the rumination, they still have symptoms, for instance, of dyspepsia, which are not gone.
So to summarize, this is a conditioned behavioral response, which is good
Yes.
because that means there could be treatments for that to reverse.
Yes.
And the pathophysiology is the conditioned contraction of the diaphragm, increasing abdominal pressure, while at the same time relaxing the lower sphincter so the food comes up. And it comes up in a rhythm, just through the diaphragmatic contractions, into the mouth, where it can either be spit out or reswallowed.
Indeed. And you know, there's some literature saying maybe these people have a transient LES relaxation after the meal, feel it, and then pressurize their abdominal wall musculature. This is not what we see. They have a zero pressure after the meal. They have a profound postprandial hypotension of the sphincter. And so they don't need to sense the TLESR. They actually can squeeze up gastric content all the time because there's never any resistance.
So I find that the characteristics you've described, which is in the Rome criteria, is so unique that maybe you don't even need to work them up. So let me ask you, what is the gastroenterologist, should the gastroenterologist do to exclude conditions like reflux or reflux or vomiting? What should be done in the workup aside from the criteria?
Of course, I'm going to paraphrase Vincenzo Stangelini here. At some point at a meeting, he was asked, we're talking about upper GI symptoms, and he said, we do an endoscopy first. And actually, he then showed that the yield of the endoscopy was low. And somebody in the audience asked, then why do you do the endoscopy? And he said, you know, if you go to a barber, you will get a haircut. If you go to a gastroenterologist, you will get an endoscopy. And so we will start with doing endoscopy in these patients, and it will be negative. And then I think it's just understanding the clinical history, asking the questions that I just elucidated, and help and using these to be comfortable of the diagnosis. And if this happens, you don't necessarily need additional examinations. You can actually go to treatment approach, explain the patient what you found, that you're convinced that you know what it is. And that is sometimes a point of difficulty, because it is not always the case that the patient is willing to follow you or is able to understand the reasoning or a combination of both. Then you do have some helps that you can use. The best certain thing is a manometry with impedance, giving a meal, looking on the impedance. You can easily see the rumination episodes. And you can see on the manometry in the stomach, they are preceded by a bump of intragastric pressure rise, and this is called an R wave. It used to be called an R wave in the past. Now, not everybody has this. Not everybody has access to impedance manometry, and not all, let's say, labs have actually the ability to do an extended measurement with a meal and measuring after a meal. There's another workhorse of the gastroenterologist, the pH impedance, which can give you some indirect hints, because people with rumination syndrome have a lot of reflux events in the 1 hour after the meal. And so if you look at that one and you see the first postprandial hour, many, many reflux events, and 2 hours later, this is a lot less, and there's no nocturnal reflux, this is not diagnostic, but indicative as well that this might be rumination syndrome. In the manometry, if you do that, and the high-resolution manometry now has nice color patches, if you have a clever patient who has some abstract thinking capability, you can actually point out a pressure rise and say, you did it again. And sometimes this helps them realize it, and has a therapeutic effect on the extremely short term. So I dwell now a lot on the manometry and the pH impedance, and of course we will have done the endoscopy, which is negative. But I think before the Rome criteria, number 4, where the manometry was actually just put in as an adjunctive, potentially confirmatory event. In the past, this was said you can do this on symptom recognition. And I do think you can do that. We do the manometries because we like to do it. It gives us insight in the pathophysiology. And to the skeptical patient, sometimes it helps to convince them. But in real life, asking the questions, it tastes like food. It starts during or immediately after the meal. It comes up in the mouth. There's no nausea, retching before. You can swallow it again. And it is with every meal, day in, day out. And it stops when the meal becomes acidic. This is rumination.
Excellent. So you don't have to work them up unless there are other reasons to do it. What about the pH study? What do you expect in terms of acid reflux? And if you do endoscopy, do you have an increased likelihood of esophagitis?
You can have a little bit of low-grade esophagitis, because not all the gastric content that is brought up is completely innocuous to the esophagus. So I think don't be fooled if you see a grade A esophagitis. This may be an epiphenomenon, actually. So that will not show it. And what was the other? Oh, yeah. In terms of acidity, no, these events are non-acidic in the first hour postprandially. Having said that, some genuine reflux patients also have non-acidic reflux events, especially soon after the meal, but there it continues way after the meal, whereas in the rumination syndrome patient, depending on the size of the meal, but 1-2 hours after, it's gone. So there is some diagnostic value, to the pH impedance. It's not certainty like the manometry impedance, but it helps you. But it doesn't allow you to tell a patient, I've seen the pH impedance, I'm certain that this is rumination. It's indirect evidence. Whereas with the manometry impedance, you can say, I've seen the manometry impedance, it is certain that it is rumination.
Very good. Well, let's move on to treatment. How are these patients treated?
Well, if you hear the pathophysiology, we should probably be targeting the pressure events in the stomach and the resistance at the gastroesophageal junction. These are two players. And actually, the best described, but not really tested in a controlled trial, but the best approach is behavioral. It is teaching the patient diaphragmatic breathing, which is easy to do. There are videos, there are plenty of videos that you can find on the internet, but actually they put a hand on the chest and a hand on the abdomen. You have them breathe in and out deeply through the nose at ease, and make them realize that what is moving is their hand on the stomach and not so much the hand on the chest. And once they realize this, they have to apply this in the setting where they would ruminate, so after a meal. And it seems that this type of diaphragmatic breathing interferes with the mechanism that drives rumination and is successful. The rates of success throughout the literature are very, very varied, but they range between something like 45% substantial improvement up to 80%. There's like between 22 and let's say a small 50% where it completely disappears with this approach. You can augment that a little bit if you can do the biofeedback, if you can show on the pressure event during a manometry what's happening, that may reinforce the act of learning and effectively applying the diaphragmatic breathing. But this is very complex, and not many patients want to come back again to have the manometry during explanation of diaphragmatic breathing. But some centers who do that say it adds something. It has also been described, some centers do EMG, intercostal and abdominal wall EMG, and correlating the movements there to the events and learning the patient how to control that. But this is very anecdotal in the literature. There have been additional attempts to add to the diaphragmatic breathing cognitive behavioral therapy, claiming that this increases a little bit the yield, and tricyclic antidepressant, but both of these have been studied in uncontrolled ways. And the reason to do that is at some point, rumination starts. And why does it suddenly start? And if you look back, some people do have a life stress event or an anxiety episode that seems to put this on top of whatever already existing or emerging gastric or esophageal symptoms they have. So that is the reason why sometimes in an uncontrolled fashion, a neuromodulator or cognitive behavioral therapy can be added. So I think this is the most effective therapy. And you can say, I don't have a diaphragmatic breathing therapist available. Look at the videos. You can do this yourself, teach it to the patient. This is a no-brainer, so to speak.
You know, it's very likely that the variation in the diaphragmatic breathing outcome may have a lot to do with the way the patient does it.
Probably.
In my own experience with patients, it doesn't work when they don't do it that often and do it well. So sometimes I go back and have them practice it in the office and kind of retrain them, which is what the psychologist would do too. Is there a role for
for the non-responders, and also perhaps as a transition, if you need it, you can use baclofen. This is what you're going to ask, isn't it?
I said, is there a role for baclofen? Yeah.
Definitely. So baclofen is a GABA B agonist. This is approved for the treatment of spasticity. And actually, so it's suitable for lifelong treatment because it relaxes the striated muscle in children who, because of cerebral palsy, are spastic and remain that the rest of their lives. Paradoxically, in the esophagus, this tightens up the pressure of the lower esophageal sphincter before, but especially after the meal. And we've done an open label trial with baclofen showing reduced rumination events on the manometry after a meal, which we did before and during baclofen. And then we did a placebo-controlled trial confirming this. And patients, also the preference of improvement was there. So this works. However, baclofen is not the drug of your dreams. It can cause drowsiness and nausea at the start. So I give it just before meals, 5 milligrams, and go up to 3 times 10 milligrams just before meals. And that is enough. And in our study with baclofen, we actually saw that baclofen increases the pressure of the sphincter, but some of these patients still make the movement. They have a pressure rise in the stomach, so they still squeeze the abdominal wall musculature, but it can no longer overcome the higher pressure that is generated in the sphincter. So I think you need the diaphragmatic breathing to get rid of that part. And you can use baclofen as a bridge, as an adjunctive, or as a rescue if the diaphragmatic breathing does not help. You can say if this is a low motility, let's give a prokinetic. There's no evidence that any prokinetic has the power to improve rumination. We are conducting a placebo-controlled trial with clebopride, but this is double-blind, it's ongoing. We'll know the outcome in about 1 year. And then in the refractory cases, it is in the literature, a couple of cases that you can do a fundoplication. And yes, if you have a wrap around the lower esophageal sphincter, you cannot bring up gastric content anymore. We've done this in selected patients, and it's not an easy solution because these people have already some dyspeptic symptoms. I think this is the basis. Then suddenly they get a wrap. They keep these symptoms of dyspepsia that were there at the origin. They cannot vent, and actually it doesn't make them happy. So I would refrain from surgery if you can. It is anecdotally mentioned in the literature. I think there are reasons, theoretical experience also, and our own clinical observation that say, don't necessarily go into that way. Try to do it with behavioral therapy, medication. You can use diaphragmatic breathing, baclofen as an adjunctive, and you can use a tricyclic or CBT as adjunctive as well.
You mentioned the prokinetics doesn't have a role, at least emptying in terms of the esophagus. If you increase gastric emptying, would you reduce the amount of rumination?
We don't know. That has never been tested. I'm not sure because actually, typically this occurs in the first hour, hour and a half after a meal. And this is when the emptying process, especially with a big meal, the first half hour, there's no emptying. So I think this is not that much related to the gastric filling. It occurs too early. Whereas if this was really an effect of too late emptying, you would think that somebody with gastroparesis would ruminate for 4 or 5 hours after a meal. We've never seen that. That makes you a little bit skeptical on gastric emptying as a target.
Well, thank you for that discourse. That discussion has been, I think it'll be very helpful for the practicing gastroenterologists and primary care as well. Part of it is to recognize it. We just don't.
Definitely.
When the patient says I'm vomiting, we take it for granted. Any final words that you might have?
No, but I think if somebody you see in your office cannot stop vomiting, ask, is it immediately after meal and can you swallow it? And if you get 2 yeses, it's probably rumination.
I would also add that when they say they're vomiting, I might say, what do you mean by vomiting? Tell me what happened.
Definitely.
Just like when they say they have constipation, because of all the possibilities of constipation. Back to you, Tanya. Any final words?
No, I really enjoyed the discussion today. I personally exercise diaphragmatic breathing 4 to 5 times a week. And so it's very, very helpful. And even devices such like Apple Watches and smart watches will even encourage that. And it's helpful in so many ways with stress, anxiety, and IBS. So thank you so much for sharing that. Thank you again for being with us today, Dr. Tack and Dr. Drossman. Wonderful to get such wonderful insights today here at Run Foundation.
Thank you.
Thank you.
Thank you.
Any final words, Dr. Drossman?
No, that's fine. We're good.
Thank you, everybody, for being here today.